Thank you, Ashfaq. Good afternoon, ladies and gentlemen. What I'd like to do is to give you a brief overview of the ventricular assist devices that are in the market at the present time. Since the advent of the cardiopulmonary bypass machine by Gibbons over 50 years ago, things have moved quite rapidly since then. This enabled the performance of open heart surgery, and nowadays we have a much more sophisticated roller pumps, and also the development of the membrane oxygenator as opposed to the initial oxygenators, which were the bubble oxygenator, had made more complex cardiac surgery possible. However, the cardiopulmonary bypass is only intended for the operation of open heart surgery, and of course it has a limited span. In the meantime, the introduction of intra-aortic balloon pump made a significant but short-lived improvement in the treatment of the failing heart. In addition to that, and of recent times, people began to use the total artificial heart, and the main examples include the CardiWest, the AbduCor, and the CarMat. The CarMat is an artificial heart which was done in collaboration with Alain Carpentier in France with the Airbus company. It was experimented in animal models, but it never reached the clinical setting. However, we have realized recently that the best way to support the failing heart is to connect the heart to a pump that sits alongside the heart, leaving the heart in situ. And this is basically the topic of this afternoon, which is the left ventricular assist devices. Those devices can be classified into short-term and longer-term. The short-term, we have the percutaneous intravascular devices and the extracorporeal devices that last up to 30 days. The longer terms are the devices that can last a lot longer than that. Examples of the percutaneous ventricular vascular devices include the Impella, and there are two types of Impella. There is the 2.5 liter per minute and the 4 liter per minute. The Impella is a catheter that is positioned percutaneously, generally speaking by the cardiologist during the conduct of a difficult angiography or a PCI. It's positioned across the aortic valve. The tip of the catheter will offload the left ventricle, and the blood using an impeller technique will pump the blood into the ascending aorta. So you'll get blood pressure support plus offloading of the left ventricle. A more aggressive and more potent pump is the tandem heart, which relies on offloading the left atrium via a catheter that is inserted through the interatrial septum, again by the cardiologist, and then the pump directs the blood through a different cannula into the femoral artery. Both of those pumps are useful in the acute stages, and they have a limited time span. If we look at slightly more aggressive pump that is suitable to the surgical setting, we can only think of the Levitronic Centrimag, which relies on an impeller that is magnetically levitated. It can attain a flow of up to 10 liters per minute, and it can last for up to 30 days. I know many people have used it for longer than 30 days, but the 30 days seems to be the acceptable period of time for the use of the Levitronics. If you can use this pump with proper integration of an oxygenator, you can change it into an ECMO machine. So this pump can actually serve both purposes. The implantable devices, and this is basically the serious end of the business. This is basically what is used to support the failing heart, have gone through 4 generations. Those generations actually reflect the technological advances that these pumps have gone through. The first generation were pulsatile pumps that use polyurethane sac that was pneumatically driven either by an external driver or a motor that is incorporated into the pump. These were the early intraventricular assist devices, example of which include the Berlin Heart, the NovaCore, and the HeartMate 1. The HeartMate 1, in fact, was very, very effective. It had an additional advantage of having a textured surface, which obviated the need for anticoagulation. However, these pumps were bulky, they had both inflow and outflow valves, and they had ball bearings and contact surfaces. Therefore, they were prone to wear and tear, and many of these patients had to have the pumps taken out or the valve replaced. Because of their size, they required major dissection and either an intra-abdominal pocket or an intrathoracic pocket, which increased the incidence of bleeding, the transfusion rate, as well as infection. To improve that, the linear constant flow pumps have come into play. Example of which are the HeartMate 2, the Jarvik 2000, and the DeBakey. The HeartMate 2 is the only approved pump for destination therapy, and it's actually it requires anticoagulation as opposed to the HeartMate 1. All of the other pumps also require anticoagulation. All of them produce a high RPM, and therefore there is a greater chance of blood damage and hemolysis, and they still need significant amount of surgery and dissection. The third generation devices, exemplified by the HeartWare, the HeartMate 3, which is coming in the future, the Ventricular Assist, and the EvaHeart. The HeartWare is in existence at the moment, and it uses an impeller which is magnetically and hydrodynamically levitated, i.e. there are no movement, there is no contact. The only moving part is the impeller that is suspended in the blood. So that has an advantage. Other advantages include a low RPM. Take, for example, the HeartMate 2. In an average patient, the RPM should be in the region of about 12,000. In the HeartWare pump, the RPM is about 2,600 to about 4,000. So we're talking about less blood damage in this case. There are also smaller pumps. The two examples are the miniaturized partial support and minimally invasive implantation. The other example is the Circulite 2 and the this is the first generation pump. The first generation by HeartWare and by the Circulite are actually coming in the future. We expect that they will be less invasive. You might be able to insert them without having to go on cardiopulmonary bypass, and maybe with minimal surgery. Now, because HeartWare have been in the news recently and have they made big impact on the VAD technology, I'm just going to spend the next few slides to explain a bit about them. The HVAD by HeartWare weighs 160 grams. It can attain up to 10 liters of flow per minute. It uses a wide blade, which is suspended hydrodynamically and magnetically. It uses a flexible driveline, which is fatigue resistant, and it's quite thin. The driveline remains one of the Achilles heels of ventricular assist devices. The driveline is what connects the pump to the outside, both for control and for energy utilization. And we will see at the end how somebody is trying to improve the situation of ventricular assist devices. The technology in the HeartWare is quite magnificent. They talk of 3 blood flows that this pump creates. There is the central blood flow, which pushes the blood in the outflow tract to supply blood into the ascending aorta. There is a secondary flow, which keeps the impeller washed. And then there is a third flow, which cushions the impeller as it is rotating. It's a small pump, therefore there is no abdominal surgery, a very small pump pocket, less surgical time, can be used in smaller patients and maybe pediatric patients. There are fewer antibodies because of less blood transfusion. This is just a real example of a HeartWare pump in situ. Future miniaturization of the HeartWare will give us a pump which is about the size of a golf ball, which is quite incredible. These are some of the trials that have been used to evaluate this pump, but I will not talk about them because I believe Dr. Kirkland will be mentioning those later on. When we talk about the driveline remains a big problem because it is prone to damage, and therefore that will interrupt the energy supply to the pump. It's also prone to infection. It is a source of infection, and many pumps have been taken out and because of the driveline infection. So a company called Levitakis Cardio has come up with a solution. And their solution is basically energy transfer. They do not sell a pump. They are not into pumps. They are trying to solve the issue of energy transfer. And they've developed a system which is composed of two units, an external unit and an internal unit. The external unit is what is on the left, which has a belt with batteries attached to it. This converts the battery energy to electromagnetism, which then transmitted across the skin to an internally located unit beside the pump. The electromagnetism is then converted into energy, and this drives the pumps. Therefore, the need for a driveline has been eliminated. This is in its early stages, and we have some in vitro experiments where they linked the system to a HeartMate 2, a Jarvik pediatric, a Jarvik adult, and a Core 8. And they've done one in vivo experiment on a pig model, which lasted for about 24 hours. And if you look at the first column, this is the RPMs attained using these pumps, using this type of energy transfer of 10,000 reps per minute, between 6.8 to 10,000 reps per minute. This is the energy utilization in watts. So it is quite high for this level of RPM. And the efficiency is, at best, say between 70 to 80%. So there is a drop in the efficiency because of the transfer across the skin. This is in its early stages. I think this will create, if they work it out and improve the technology, and I have no doubt that the technology will become possible in the future, because as I said, the driveline is the Achilles heel of that technology at the moment. We will see a big explosion in ventricular assist devices usage. In the end, ladies and gentlemen, I think that the gap between the normal physiology and the technology is what drives the innovation. It is a rapidly moving field. Many people are coming on the market and competing with each other, which is good for us and good for patients. New materials, and again, the solution to the power supply might push it even further. And we hope that with increased applications and elimination of the driveline, more people will be interested in it. Thank you.